today our goals are to show you how a psychiatrist evaluates a child with developmental disabilities for psychiatric disorders, to let you know what medical evaluations we consider in the process of this evaluation, and what interventions to consider. We generally recommend multidisciplinary interventions, but because of the limit of time and the scope of our presentation, we're going to focus more on psychiatric interventions. So this is a brief outline of what you're here today. Dr. Gutierrez will be giving you an overview of the inpatient and outpatient course. I will be presenting a differential diagnosis, and Dr. Brandbott will be reviewing an article that's relevant to our case presentation today. And then I will summarize the presentation at the end.
This afternoon I'm going to present to you a case that, a patient actually, that all three of us have taken care of at one point during his course. And I'm going to present the story to you as it unfolded for us and actually continues to evolve. So our patient is an 8-year-old Caucasian male who initially presented to us for his first inpatient psychiatric hospitalization. His mom brings him in with a chief complaint of command auditory hallucinations, telling the patient to harm himself and others. The patient describes the voice as a running commentary in his head, and he is observed to hit his ears to stop the voices. He's also observed to turn up television volume to block the voices. There's an unclear correlation between these psychotic symptoms with any mood symptoms. There's no history of trauma or any repetitive behaviors. Patient described occasional episodes of fast heartbeat and had difficulty with aggression at school. In the past year, he had actually been expelled from his school for attacking 12 students and 2 adults. He's also had chronic trouble sleeping. He's had no prior psychiatric hospitalizations, and he was currently at the time taking olanzapine 5 milligrams and fluoxetine 20 milligrams a day. He had been diagnosed in the past with bipolar disorder, attention deficit hyperactivity disorder, and pervasive developmental disorder not otherwise specified. His family history was positive for bipolar disorder. His developmental history was not reviewed in the hospital, and his social history, he comes from an intact family with both parents, where he is the youngest of 3 children. On initial mental status exam, he appeared his stated age with no obvious dysmorphic features. He had normal grooming and hygiene, fair eye contact, and fluent speech with normal prosody. He had increased motor activity and was unable to sit still. He reported his mood as sad, irritable, and angry. His affect appeared sad. His thought process was coherent. His thought content was positive for suicidal and homicidal ideation. He reported currently hearing voices calling him dumbass, but he did not appear to be responding to internal stimuli. Cognitively, he was able to spell his name backwards, perform some simple multiplication and subtraction, and he also had some soft neurological signs. His initial laboratory workup revealed normal general chemistry panels, complete blood count, and urinalysis, except for some minor fluctuations as listed here. His fasting lipids were slightly elevated, and he had a normal TSH with a borderline abnormal free T4, free thyroxine level. He had also had some previous psychological testing done when he was 6 years old and 6 months old. His WISC-4, Wechsler Intelligence Scale for Children, showed about low average intelligence with a verbal comprehension score of 81, perceptual reasoning of 92, working memory of 104, processing speed of 88, and a full-scale IQ of 88. A Stanford Binet test done a couple months later again corroborated low average intelligence with a full-scale score of 87, nonverbal score of 88, verbal score of 87, and an abbreviated IQ of 106. However, he did score high average on his knowledge factor index. His speech assessment showed average abilities with a specific weakness in pragmatic language. He had also had some various rating scales for the autism spectrum symptoms and scored high on the Asperger Syndrome Diagnostic Scale, as well as very high for autism spectrum symptoms on the Social Communication Questionnaire, the Gilliam, and the Childhood Autism Rating Scale. However, an Autism Diagnostic Observation Scale, or ADOS, done by the Alta Regional Center came back negative. His Vineland Adaptive Behavior Scales, which captures his activities of functioning and daily living, showed very low scores in the 1st to 3rd percentile in areas of communication, daily living, socialization, and motor skills. So initially in the hospital, he was quite agitated. He required emergency haldol-paridol injections to control his behaviors. As it appeared that his current outpatient medications were not adequately controlling his symptoms, these were stopped and he was started on risperidone and titrated up to 1.5 milligrams twice a day for his auditory hallucinations and psychotic symptoms. However, even after being on this, he remained quite irritable with insomnia. At this point, oxcarbazepine, a mood stabilizer, was initiated and titrated up to 300 milligrams twice a day for mood stabilization. On these two medications, his mood and psychotic symptoms and behaviors improved, and he was improved. Interestingly, there were two incidences of falling during his unobserved falling while he was in the hospital. One occurred while he was sitting in a chair, and another occurred while he was in the shower. The second incident actually required 3 stitches on his head. And as these were unobserved, it was unclear exactly what happened, but a 24-hour EEG was ordered at this time to rule out a possible seizure disorder. So patient was hospitalized for about a week and discharged to outpatient follow-up. He initially followed up in the outpatient psychiatry clinic a month after discharge. He presented then as quite disorganized, hyperactive, and labile. Mom reported that she had been close to rehospitalizing him several times in the interim since discharge. At this time, additional history was obtained. Mom reported that she had had difficulties with him early on. Her pregnancy was complicated by anemia and her own emotional distress. She had a long, complicated delivery, and patient was born nose first with trauma. Mom also reported that there had been a history of cyclical mood fluctuations, and patient had expressed chronic suicidality with no previous attempts. He had a long history of psychiatric treatment and had been tried on multiple medications in the past. Developmentally, she described him as an irritable baby with difficulty feeding, frequent tantrums, and poor eye contact. And he had normal motor development, but had difficulty with social interactions. The family history was further elucidated to find bipolar disorder not only in mother, but also an older half-sister. Father and brother also had diagnoses of attention deficit hyperactivity disorder. There was also a history of learning disorder and dyslexia, and failure to graduate from high school in many relatives in the family. And although the patient himself had no abuse, there was a history of abuse-related traumas in the family, including the mother herself. So initially, patient's mood in the outpatient clinic was quite elevated. His affect was expansive with odd smiles at inappropriate times. His thought process bordered nearly on flight of ideas with brief fixations. He reported hearing 500 to 10,000 voices telling me to die and kill myself. He was hyperactive, disruptive, intrusive. He needed constant redirection. He had poor avoidant contact and was constantly moving about the room. He had poor spatial boundaries, often rubbing up against me with no apparent regard. He had awkward social interactions. His speech had an elevated tone and odd prosody. At this point, we decided to increase his oxcarbazepine from 300 to 400 milligrams twice a day to target his mood symptoms. This did improve his behavior and decreased some residual hallucinations. However, he continued to have problems with attention and impulsivity. At this point, methylphenidate was cautiously restarted, as it had been, he had been on it in the past, but it had been stopped due to concerns about it causing psychosis. But at this point, his methylphenidate was restarted and titrated up to 54 milligrams. He continued on these 2 medications, including his risperidone, 1.5 milligrams twice daily. And on these 3 medications, his mood and hyperactive symptoms greatly improved. However, Mom reported that the afternoon period continued to be a difficult time for him. Patient was on a baseball team, and following the rules of a baseball game as well as the social engagement was quite difficult for him. However, the baseball coach was able to make him a catcher, which was a good fit for him as it involved him in every play of the game and also gave him a specific task. Mom admitted that she continued to have a difficult time providing him with structure and behavioral consistency, which often resulted in him having frequent tantrums. And Mom also reported that she was unsure whether, when he reported some symptoms, whether it was an attention-seeking maneuver. It was at this time that he reported seeing ghosts and hearing voices again.
Okay, so in summary, we have an 8-year-old Caucasian boy who has a history of speech delays and social difficulties, who presented for acute hospitalization with complaints of command hallucinations to suicide and harm others. He was observed in the hospital to be physically violent to himself and others, in addition to having seizure-like symptoms. In the outpatient care, he continued to have abnormal mental status findings of agitation, complaining of voices commenting on his behavior. His previous MRI findings of a nonspecific white matter hyperintensities were not reproduced in the follow-up MRI. His EEG findings initially of a spike wave activity in his occipital lobe may be improved in the follow-up EEG, being on anti-epileptic. The treatment with the antipsychotic mood stabilizers and stimulant medications overall seem to improve this child's behavior. So at this time, I'd like to move to the differential diagnosis of schizophrenia, bipolar disorder, and seizure disorder. We will only review these diagnoses here because of the limitations of time. The discussion of other developmental disorders such as ADHD, I shall leave up to you to discuss outside of this arena, okay? Because I like to discuss these more controversial diagnoses in depth. So the debate about psychopathology in children continue to evolve. Even though many epidemiologic studies have suggested that 50% of all psychopathology present by age 14. The burden of disease in the United States is quite significant, with 5.7 million adults with bipolar disorder and 2.4 million adults with schizophrenia. International studies have shown that the prevalence of these disorders are consistent across different ethnic groups as well as geographic groups. The controversy of bipolar disorder being overdiagnosed in youth remains very hotly debated. It's a topic beyond the scope of today's presentation. I will simply present some relevant data to support why this young man might have bipolar disorder. The diagnosis of schizophrenia in youth appears less controversial, however, it remains a pretty rare finding in children younger than 12 years old. Schizophrenia prior to age 12 is designated as childhood onset. It's been carefully described and studied by Judy Rappaport and her colleague at the National Institute for Mental Health. I had the opportunity to work with Jean Fraser, who helped describe a large group of children enrolled for a study on childhood onset schizophrenia. A majority of the children who were referred for this study did not actually meet criteria for schizophrenia. However, a similar number of children who did not meet criteria for schizophrenia met criteria for an affective disorder, which is usually depression or bipolar disorder. Interestingly, a large group of children fit a different category, which they describe as multidimensionally impaired. The children who were diagnosed with childhood onset schizophrenia had many premorbid symptoms shared by the patient presented today, such as ADHD, speech and language delays, disruptive disorders, and some autistic features. However, many of the children who did not meet criteria for childhood onset schizophrenia but met criteria for multidimensionally impaired also shared many symptoms with our child presented today, such as emotional lability, poor reality testing, ADHD, attention deficit hyperactivity disorder, poor social skills, cognitive impairment, and onset prior to age 7 years. Note that the children who are grouped in this multidimensionally impaired category are excluded if they have mental retardation, pervasive developmental disorder, or a neurologic disease. So by this definition, our case today would be excluded from this multidimensionally impaired category if we believe this child really had a seizure disorder or met criteria for autistic disorder or Asperger's syndrome. He would also be excluded from this category if we believe his symptoms of thought disorder or psychosis were actually real and substantiated. As you all know from being in this audience, illness in a child is quite fluid. And in most studies, research studies in particular, the description of illness is often cross-sectional, just one time point in a child's life. So, if we had actually met this child when he was 6 years old at the time that the Alta Regional Center testing was done, and we decided he was ruled out for autistic disorder, we might have diagnosed him with multidimensionally impaired. So, as I mentioned earlier, due to limitations in time, I'm going to defer discussing the controversy around diagnosing young children with bipolar disorder. Instead, I'm just going to summarize the MRI findings in pediatric bipolar disorder, which this patient actually shared at one time point, okay? A large review of adult studies have shown changes in the temporal lobe, the amygdala, as well as nonspecific white matter changes. White matter is basically the areas of the brain that connect other areas of the brain, okay? I think you've heard about this probably a lot today. These same findings have actually been reproduced in children with bipolar disorder. And as I mentioned, our patient did have one MRI, which shows some of these nonspecific white matter changes. I'm sorry, I can't explain to you why in the second MRI those changes were no longer present. White matter changes in children are usually thought to be due to some type of hypoxic event. And so children's brains are plastic. They do recover. Perhaps he recovered from whatever injury that initially caused those findings. I myself published in 2008 a study that showed that children aged 7 to 13 with bipolar disorder may have a small left anterior cingulate gyrus compared to normal children and children with autism spectrum disorders. For a researcher, this is very exciting, especially in imaging, because pretty much whenever you look at a brain region, regardless of diagnosis, they seem to be effective. So it's nice to find one brain region that's effective for one disorder and not found in another disorder. However, the anterior cingulate is very important because this has been shown by Cam Carter at UCD Department of Psychiatry to be important in the regulation of attentional processes, which are frequently problematic in people with schizophrenia and bipolar disorder. However, these differences in the volume of the anterior cingulate gyrus as well as the amygdala, you can't see in individual MRIs. So we can't measure a child's MRI and say, oh, your amygdala or your anterior cingulate gyrus is smaller. These are mainly averages between groups. So I think you all probably realize at this point, the big question is whether this child really has a seizure disorder. And I wish we had a child neurologist here in the audience. Maybe they could help us. We've been working closely with a few child neurologists in the community, and as you can imagine, no one really seems to agree. So the issue of psychiatric symptoms and seizure disorders remain pretty hotly debated in our local community, and that's why I've asked Dr. Brombach to present an article to discuss some of this controversy. Prior to that, I'm going to briefly discuss our patient's findings and its relevance to a seizure disorder. Because as our patient, improved, his EEG did improve, and the second EEG didn't show any spike wave discharges. However, as most of the neurologists will tell you, he did not actually have any seizure activity on his EEG. Okay. So the important finding in the second EEG is that he showed what they call occipital intermittent rhythmic delta activity. So I do what I do best, which is a PubMed search. Okay, and when I reviewed the PubMed findings, there were only 2 published case reviews regarding this type of finding. The first was published in Journal of Clinical Neurophysiology. They reviewed retrospectively 77 EEGs, which showed the finding of the occipital intermittent rhythmic delta activity. They then reviewed the clinical histories to determine whether these children had a seizure disorder, and they ascertained that of these 77 EEGs, 69 of those cases actually had a seizure disorder. The average age of the children with seizure disorder was 7.6 years. The second publication was in Epilepsy in 2007. They reviewed 697 consecutive pediatric EEGs. Their population, the mean patient age was 7.96 years. And again, in reviewing the clinical history, the medical records, they decided that there was seizure activity in 50% of these cases.
I'm going to try my best to do justice to the question of seizure and the psychopathology and all the overlapping and confusing diagnostic criteria that he meets and doesn't meet. So the paper that I'm going to briefly review is really addresses psychiatric comorbidity in kids who have epilepsy, but not just epilepsy, new onset epilepsy, to get a sense of, is this something that happens over time or you see it pretty early on. But to go over just some brief background data, if you look at rates of psychiatric disorders just in the general population, it ranges anywhere, and these are all diagnostic categories. It ranges from 7 to 10%. But if you narrow this down to people who have medical illnesses, non-neurological medical illnesses, it's a little bit higher, 10 to 12%. If you add epilepsy in the picture, it really jumps to 26 to 29%. And then if it's complicated, where it's not treated well or they're having intractable seizures, it is as high as 56 to 58%. And these numbers are not from any single study. Actually, if you look at a study done in 1970, the Isle of Wight study, it shows these numbers. And a much more recent epidemiological study in UK in 2003 had very similar numbers. So these numbers are very stable and very real. And even with other medical illnesses that are chronic, unpredictable, severe asthma requiring intubation, all those things, there's still something about epilepsy that we see much higher rates of psychopathology in this population. And it's likely it's got something to do with common neurological pathways that are underlying all these disorders. There has been some question that has been brought up about whether mental health disorders or psychopathology could actually predate the seizures, or before you see seizures, you might see some psychiatric symptoms. Some of the, I'll talk about the specific study, but there are some studies that have been done before that one that were mostly based on parent and teacher reviews, and there could be some recall bias in terms of whether or not symptoms were there before the seizure or not. When they do occur after seizure onset, really the severity of the psychopathology, the census depends on seizure variables like localization, how severe it is, what kinds of medications they're on, as well as how much it really taxes both the coping skills and the resilience of the patient and the social support system in terms of how extensive the psychopathology and its burden is. So, having said that, I'm going to delve into this paper a little bit, where the goal that they set for themselves when they did this study was to really look at kids who had seizures and look at them pretty early on after their diagnosis, compare them to control groups who didn't have any seizure or any other issues, and see the relative risk for psychopathology, and really look at the entire kind of DSM-IV diagnosis or criteria, all the different diagnoses, not just narrow categories of depression or just anxiety or just attention deficit. And what they really wanted to kind of look into was getting a temporal sense of what came first, if you may. Was it the psychopathology that was seen first, or was it really the seizure disorder that came first? And then they wanted to make sure that they ruled out any contributions from other factors like neurodevelopmental issues or epilepsy-related features or demographic features and other things. So the way they designed it was a case control retrospective, which basically means they kind of looked at information going backwards. And the patients that were recruited were from a tertiary care clinic affiliated with the University of Wisconsin. And all of these cases were new onset seizures that they were diagnosed within the last year with a seizure disorder. And basically they had to exclude that they didn't have any other developmental disability or neurological illnesses. And then the control group were first-degree cousins of these patients. Again, should not have any seizure-like episodes, or febrile seizures, or loss of consciousness, longer than 5 minutes, and also no relatives with that, first-degree relatives with that history. So once they kind of set these criteria, they found 105 patients, were able to recruit 75. They reported data on about 53 kids, so really I couldn't find what happened to the remaining 20-some kids. But that's the data they report, 53, both in the control group and the study group. And what they did is administered the KIDDIE-SAS, which is the kiddie version of the Schedule for Affective Disorders and Psychosis. It's a pretty broad scale. And it was administered both to the child and the parent. And then the data was gathered and evaluated. And then they made extra sure that their diagnoses were correct by doing an independent review in 15% of those results. Basically, they did some statistical analysis on that, and their primary goal was to look at the proportion of psychopathology in groups with epilepsy versus without, and then within the epilepsy group, in those with focal versus generalized seizures. And they did some supplemental analysis to make sure that other features like demographics or seizure variables were not contributing to this difference in psychopathology. So what they found, kind of the table one which talks about just demographic features, that the two groups were pretty comparable. There were no differences in age, sex, or seizure variables, or localized or generalized. So they were pretty comparable, and so that we could say that it's pretty fair that the findings are true. Then when they looked at the group with epilepsy versus the control group, they found really high rates of all internalizing as well as externalizing psychiatric disorders. So anxiety, depression, attention deficit hyperactivity disorder, and maybe some trending towards tics and oppositional defiant disorder. What they didn't see a difference in was psychosis between the two groups and conduct disorder between the two groups. Those rates were pretty comparable. Then they further, when they broke it down in the seizure group, localized versus generalized, they saw maybe a few more symptoms of tics if it was a focal seizure, and maybe a little more conduct issues if it was generalized. But the numbers were really so small that I'm not sure we can use that to make any kind of clinical call or judgment. So then they, kind of looked at, okay, so within the different, psychopathology groups, is there a specific thing that puts you at higher risk for depression versus anxiety versus something else? And they found really no difference as far as depression goes. The sense was if your seizure started early on, you were at higher risk for anxiety, and that if your IQ scores were lower, you were at higher risk for having attention deficit hyperactivity disorder, though that's tricky because they didn't really address if their attention deficit hyperactivity disorder was treated or not, and if that impacted their scores being low because they were so distracted they couldn't finish the tests, or how that, they didn't really address that issue. And then they found that as far as, anxiety and depression, anxiety and something else, or depression and something else, it was pretty comparable in how they co-occurred. So next, kind of to what their main goal was to address this temporal issue of, is it the seizures that came first, or is it the psychopathology? What they basically did is had independent reviewers look at medical history and psychiatric history and decide what was the onset timeline. And then they combined that data and found that about 45%, so nearly half of the kids, had psychopathology that came before the seizure disorders, that they actually saw depression, anxiety, and ADHD, or attention deficit hyperactivity disorder, much more before than actually after seizure onset. So there's some evidence, and it kind of adds on to some of the other studies that say you could actually see psychopathology first without seeing a seizure disorder, and it might just be kind of how they present, and maybe because of some underlying pathways that are common. So basically what they concluded from this, and what we do know very well, is that there's high rate of psychopathology with seizures. But this is also true for new onset, so it's not necessarily just the burden that comes with years of having had seizures, that this is something that starts pretty early on and points maybe towards, again, the underlying common pathway. That it's predominantly attention deficit hyperactivity disorder, depressive and anxiety disorders that come on earlier and maybe even before the seizures are brought on. Again, there, some of the points to discuss with this paper, it was pretty, 53 is a relatively small number. It's a tertiary care clinic. You would expect that most of the cases referred there were complex, that they had kind of been, referred further and further because they weren't able to be managed at primary care levels. The question about more attention deficit hyperactivity disorder, if you look at the age ranges that, their sample group was from, they were beyond, or 6.7 and above. And really, we make a diagnosis of ADHD, the onset has to be before 7 years, and so that might have skewed the numbers because we just see that early on versus depression or anxiety or other things where the average age of onset would be a little bit higher, irrespective of other factors. And then they kind of briefly mentioned that there were no contributions from anti-epileptics to this difference in psychopathology between the various groups, but we do know that there are various medications that are used for seizures that can have side effects that are psychiatric in nature. So how much that contributed is also something that we don't know. So, having kind of discussed this, what I really want to emphasize is, like, if you think back to our case, one of the questions that we have been thinking, is this a seizure or not a seizure? But it might be that some of the psychopathology is something that we're seeing before actual symptoms of epilepsy. And so some of these kind of vague EEG signs might be something that we might further down the road see a seizure or not. So it kind of might not answer the question whether he has a seizure or not, and part of it might be because we're seeing the psychopathology first. And again, kind of because one of the questions from the video you saw was like, are these non-epileptic or pseudo seizures? And this is a question that comes up a lot. And so what the gentleman here had just mentioned, that you can see pseudo seizures even if you have true seizures, because having a pseudo seizure does not rule out a true seizure disorder. In fact, if you look at epilepsy patients, so these are patients who have documented EEG changes and have true epilepsy. In the outpatient, about 5 to 10% of them will have co-occurring pseudo seizures, and on the inpatient unit, it's actually as high as 20 to 40% of these patients. If you look at kids specifically, the data number percentages are adult data, but if you look specifically at kids, there are some case series that really talk that for kids with true seizure disorders, as early as 5 months after the diagnosis, you will see some pseudo seizure activity, but that is not diagnostic. So really the issue with that is we really just want to diagnose it early on and recognize the pseudo seizures early and treat it so that it doesn't become a chronic problem. More often than not, neurologists rely on kind of video EEGs where they're taping the patient while they're having an EEG so they can correlate the physical activity with the EEG changes. And treatment really consists of pseudo seizures, of treating the underlying psychiatric disorder, because there are some underlying issues that I will talk about in a bit, and then therapy, either supportive or cognitive behavioral therapy, depending on what the underlying issue is. So some of the common underlying factors that we do see with pseudo seizures is misinterpretation of their physical symptoms, and that we see more so in kids who have some kind of an intellectual disability where they really misinterpret what's going on with their bodies. Anxiety disorders, including PTSD, depression, somatization, hypochondriasis, dissociative disorders, and conversion disorder. Sometimes it's a reinforced behavioral pattern, which maybe the mom in this case was questioning if this is a way he's learned to get attention. Response to acute stress, and rarely, but in rare cases, we do see underlying psychosis. So it kind of, again, because these were all questions with the patient, it kind of leaves us with, so how do we treat a kid like that? What is the guiding principle? He doesn't really fit any neat box. It's not this disorder, that disorder, but there are just kind of like these symptom complexes that he has. And in psychiatry, when we're treating kids, we really kind of rely on DSM diagnosis and meeting criteria and then treating according to what DSM diagnosis they meet. But in cases like this, we're really left doing more symptom treatment. So we really have to kind of look at symptom complexes and treat that. And so that's how I'm going to really talk about the treatment, and going to really limit it to talking more about psychosis and why that was kind of something that we chose to address first. And then, as Dr. Chu said, the bipolar diagnosis is really kind of a whole topic in and of itself. So the reason why it is really important when you see any psychotic symptoms to intervene early on, because there are some very good studies, even meta-analysis, that talk about the importance of intervening early with any kind of psychotic episode in terms of improving long-term prognosis or reducing the chances of worse outcomes even with first episode of psychotic features. There's even studies that even if it is sub-threshold, so they don't meet criteria for schizophrenia or a DSM-IV diagnosis, but they have some symptoms of psychosis, that treating that might prevent it from converting to a full-blown psychosis or actually having a first episode. And so, given all of that, it really became imperative that we intervene and treat this kid, even if we didn't have a clear diagnostic box to put him in. And so some of the common medications that we use typically for psychotic symptoms, atypical antipsychotic medications, they're listed here. They're approved for various age ranges, for various disorders by the FDA, but they're used pretty commonly. The one that's missing from this list that's used commonly in adults is geodoner, and that's not approved for kids, and that's not something that we frequently use. As far as lithium that's on the list, that's a mood stabilizer, can be used for bipolar disorder. There isn't a study, so it's not something that was approved because studies proved that it worked and that it was safe, but it was grandfathered in because it had been used so extensively with adults and that's true of a lot of medications that's used for either experiences in the adult world, or it works for one disorder, so it might be tried for something else. And with that, I'm going to end here and give it back to Dr. Chu to summarize. Thank you.
All right, so here's the concluding slide for the diagnoses, but I'll follow up with a summary for some take-home messages, okay? So, yes, so the reality is that, the underlying pathology for this child really may be more complicated than our current medical technology will allow in making a diagnosis. Fortunately, recent cognitive neuroscience research shows that many different parts of the brain really work together to control our basic emotions. This picture of the brain here really summarizes one model that's actually proposed by Ralph Aldolf and Michael Spezio in their paper that's entitled The Role of the Amygdala in Processing Visual Social Stimuli. So what you'll notice here is this is the primary visual cortex. This is where the child was having some abnormal activity, the delta wave activity. That's the occipital lobe, okay? The occipital lobe here is the center for primary visual attention. The primary visual attention area is important for modulating visual attention. And now we know that visual attention is really important for how the amygdala interprets a face showing fear. So this is the amygdala. You can see through your visual cortex the fear, okay? And it depends on how long you look at that. And it's going to modify how the amygdala then influences the other parts of the brain and how the brain reacts to a face showing fear. Now, white matter in the anterior cingulate, which I mentioned earlier in the studies about bipolar disorder, these are important control centers for attention. And some of you may have heard in the last month, there was a study that suggests that the duration of gaze, which is really a proxy for attention, for a face showing fear, may actually predict whether combat veterans develop post-traumatic distress disorder versus depression. So at this point, I'd like to just highlight some of the key take-home points from this discussion. I personally believe that all children with developmental disorders should be screened for psychiatric symptoms. When evaluating a child, psychological testing is critical, and I think you heard Dr. Brombach say, and I will really emphasize the point, we need to know the cognitive potential of this child because younger children do misinterpret their physical somatic symptoms, okay? But also, it also helps us better understand whether children are really having psychotic symptoms or not. People often ask me, how do you differentiate between an imaginary friend versus true psychosis? And that partly depends on psychological testing. Because the younger the child, it's normal for them to talk to themselves, and they're not really talking to auditory hallucinations. And then many people ask me, how do I decide whether to get an MRI or EEG? I have worked in many settings, and every time I try to order one of these tests, people groan at me, okay? Honestly, they're not that expensive. An MRI will cost you $800 to $900 these days. And, our psychotropic medications are very expensive. A course of Seroquel for 1 month is $500 to $800. That's the cost of one MRI. Okay, so just to sum up, the things that I looked for in this child that really motivated me to get the MRI and the EEG was based on the psychological profile. He had an inconsistent psychological profile. He also had a history of social issues as well as speech delay. So the other developmental issues really made me, want to get an MRI and an EEG. And of course, the falling in the hospital certainly, really help with that. Many people have asked me whether we should do genetic testing in children. I get a lot of groans from the administration because I do a lot of genetic testing. Again, it's based on the developmental issues. If I see a lot of developmental issues, I generally will start considering genetic testing. If the child has dysmorphic features, I will definitely get the genetic testing. I didn't do it in this child because his dysmorphic features are relatively mild, but we're in agreement that most likely that would be beneficial in this child in the long-term treatment. So in terms of the treatment, as I said earlier, our focus has been on the psychiatric treatment because that's our specialty, but also because of the limitations of time. I strongly encourage a multidisciplinary approach. When people work with me and talk with me, they know that I take a very systemic approach. I've talked to chaplains, teachers, psychologists, just generally anybody who has any investment in the child. So it's not meant to be biased to psychopharm here. The reality is, as Dr. Brombaugh mentioned earlier, it's very difficult to diagnose children with a specific diagnostic statistical manual disorder. And I always like to spell it out because I like to remind people that, this diagnostic manual was really meant for research. I don't know whose bright idea it was to make it, for coding and billing and reimbursement. So what we really do in practice is we don't really rely on the diagnostic manual and the diagnoses themselves. As you see, we tailor our practice to targeting symptom clusters, and our symptom clusters do fall in psychosis versus mood versus attentional issues. What we really like to share with you today, people always ask me, what my viewpoint is on medications, and I tell them I'm pretty much in the middle of the road. I use medications. I also take kids off medications. Many kids I evaluate don't end up on medications, okay? But when I use medications, I will start with what's been approved by the Food and Drug Administration, what are approved treatments. So when the pharmaceutical companies come talk to me, they're like, how do you decide? I said, well, you're approved, okay? So once we go through those medications, then the most important second step is then to proceed with medications that have been published with evidence-based trials. Okay. So in summary, I'd like to thank Dr. Brombaugh and Dr. Gutierrez helping with today's presentation. I didn't have to twist their arm too hard. And also, I really like to thank the audience for their wonderful participation. And I'm going to leave you guys to decide whether when you hear hoofbeats, which is something we used to say a lot in medicine, I don't know if they still say that, when you hear hoofbeats, you generally should think that horses are coming. Sometimes you might have to think that zebras are coming, particularly my colleague who used to make fun of me for making all these weird diagnoses. He's like, when you're in Africa and you hear hoofbeats, they're actually really zebras. Well, when you're in tertiary care medicine at a nice big university like University of California, Davis, you hear hoofbeats, you generally will see zebras, okay? But unfortunately, I'm more known in my field for seeing unicorns.
The UC Davis Mind Institute was created in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other brain disorders are helping children achieve their fullest potential. Please visit our website to find out more about current studies, upcoming events, and how you can help make a difference.